All
Great.
right.
Welcome
Go
back,
ahead,
everyone. Thank you. So we have time for a couple of questions. Dr. Levitsky, I have a question for you. You mentioned, some patients can have some pain after RFA. If a patient calls and they're, really struggling, what are some things that you could tell, an APP to prescribe for them?
Yeah, so typically I'll prescribe right at the time of the procedure a GI elixir, which includes a liquid form of lidocaine, an acid neutralizer that includes Gaviscon or Maalox, Benadryl, and most importantly, I tell them it's self-limiting. It's usually that first day post RFA that people feel pain, and they, by the third day, it's getting better. So it's really a lot of coaxing them through it. If it's really, really severe, at times we can use liquid opiates. I try to steer clear of that in 2021.
And do you use viscous silocaine at all?
Viscous lidocaine, absolutely, and it is part of that elixir.
Yeah.
I'll also use sucralfate and heavy PPI doses post-procedure to help with GI mucosal healing.
I had a question for Ben and for Charu, again on the same lines with Barrett's. Do you guys ever think about or consider fundoplication for some of those refractory patients? You've ablated them a couple of times, they keep having it come back. We know that reflux is a component of this. So what are your thoughts about anti-reflux surgery in that setting?
So I'll go first. I think the thought process is very clear that we all know Barrett's is from reflux. And if the patient is younger and they still have, many decades in front of them, I think, it's great that we can treat Barrett's endoscopically and, eradicate it. But then we're going to look at it again in 10 years and going to be in the same boat again. And actually, Demister and their group and some other groups have actually done a great work on this and have shown that long-term, it's actually beneficial to have anti-reflux surgery in this younger population after you eradicate the Barrett's. So I think, I always discuss this with the patients and show them the data. There is enough data now. About 10, 15 years ago, there was not a robust data about this, but now there is great data to show that the Barrett's can be actually controlled and in some cases actually reversed with anti-reflux surgery after ablation. Ben, what are your thoughts?
Yeah, well, first of all, I think that the key here is to eliminate esophageal acid exposure causing esophagitis in whatever means necessary, number one. And number two, I think that making sure that Barrett's is fully eradicated before moving to a Nissen is also important because it can actually complicate the process of eradicating it with RFA if there's anatomic changes. But I think it's a reasonable approach once you have achieved complete endoscopic eradication.
On that line, actually, I have a question for you, Kumar, and also for Christina and other APPs that are here. That, very few centers, unfortunately, have a robust Barrett's registry. And, what are your thoughts on having that? I know it's a cumbersome thing to develop and have, but do you think every foregut or heartburn center should have a comprehensive Barrett's registry?
It's a good question because it was very in vogue about 10 years ago when Barrett's therapy was kind of newer. People didn't know how endoscopic therapy was going to work. So these huge registries were developed, and I was part of a couple of them. Obviously at UNC, Nick Shaheen has created this whole multi-center cohort of Barrett's registries. It's sort of fallen out of interest mainly because the efficacy of RFA has been proven. However, I will say that if you're a center that deals with Barrett's, having an outcome registry is critically important, because you ultimately have to see, how are your patients really doing? Are you eradicating Barrett's in 3 to 4 sessions, or are you ablating people 7 to 8 times? And so how aggressive are you at controlling reflux? We had published a study a few years ago about aggressive anti-reflux measures, which ultimately improve eradication rates for Barrett's in those patients who are undergoing eradication therapy. So it's one of those things. It's almost like adenoma detection. I think that it could serve a very good quality metric.
I agree with that, and I think this is where a multidisciplinary group can really hone in and develop something like that. So no, I agree 100%. We have to follow these patients. We have to understand trends and how we are doing with the treatment of these patients. So
I also think it's really critical to not lose people through the ether that have either low-grade or high-grade dysplasia. To me, those are the ones that we cannot miss, because those are the patients that are going to have problems.
And I think in line with that is, we know that some of these patients have recurrences. In the original sort of Barrett's trials, up to 25% of them have recurrences in 2 years, and a fraction of those have recurrences in the form of high-grade dysplasia. And so that's exactly the patient population that you don't want to lose. And then they come back with something much worse 4 years from now. So I think that's a very good point, Ben.
I also kind of want to mention too, is with a lot of our patients, we have to really make sure that they're aware that just because we do a treatment plan on them doesn't mean that they're, kind of done with the disease. So a lot of times patients will say, well, I'm coming to get my anti-reflux surgery because I have Barrett's, but whatever the, even if it was just intestinal metaplasia, and they're shocked to find out that they still need endoscopic evaluation even after the surgery. But this is where I think too, we have to really, use our ability to educate these patients and say, hey, listen, we're doing the best we can to prevent the progression of your disease, but we also need to make sure we monitor you on a regular basis.
I think, Christina, that's a great point, because, even though there are some vague guidelines about how you monitor Barrett's after it's been actually ablated, the data shows that not all patients actually get that. And that's going to be the problem going forward. With that, actually, I want to ask Kumar and Ben that, endoscopically, when you look at it and you rule out it's not a nodular disease, it's just a flat looking disease. And do you have a protocol where you always do EUS before you ablate them, or you just go by the looks and ablate it?
What do you think, Ben?
Well, so the 2020 article in Gastro by Sharma really steers us away from routine EUS on all patients. If you really, it's those patients, I showed one slide that showed non-dysplastic Barrett's has a rate of lymph node involvement that's very low. And of the patients that, have intramucosal cancer that isn't going down to the submucosa, those rates are also low for lymph node metastasis. So I'd say, number one, the considering EUS on all patients, I think, is more at this point, there's a medical legal side of things. It's not mandated at this point. If you have someone who has even a hint of submucosal disease or T1B disease, I would definitely want to make sure there's no lymph node involvement. But in general, it's not mandated.
Yeah, I mean, I think that if somebody has a nodule, I probably will do it. But the reality, though, is we know that EUS does not have the best reliability for T staging, especially distinguishing T1A and T1B. And that's where EMR is helpful. There are some groups that for short segment high grade, they'll just EMR it. And I mean, I think I've kind of trended towards that a little bit more. Initially, there was a little bit of hesitation about ablation because, if it's high grade and how do you know you've gotten rid of it, you don't have the tissue. But those discussions were gone about a half a decade ago because the data on ablation is just so robust now that we don't really have to worry about it. So I think EUS in select situations, I think more importantly than EUS, doing a very good EGD. The scopes are great now. And, if you have a long segment, spend a lot of time looking at it. Many times you'll find a small nodule. And that's what you want at EMR.
I would also add that not only are our scopes great, the narrow band imaging on the scope is just fantastic these days. And you can pick up changes in the pit pattern and the mucosal variability in ways that we just never used to. So I agree entirely with Kumar.
That's great. Thank you. Changing gears, I have one question for Andrea. That was a great talk, Andrea, and we all have seen those patients who I'm sure can benefit from the hypnotherapy. How do we get the patients to you? Can you let us know, and also to the viewers?
Sure. So right now, because we're really building our behavioral health program, so I am doing a lot of referrals within our practice. So we haven't really expanded too much further than that. But what we typically do is if someone has a patient they identify, they'll reach out to me or to one of the psychologists, and then they'll ask us to see them in clinic. But I do hope at some point, because there really is a demand, that we can grow this even further. So about a year or two ago, we didn't have cognitive behavioral therapy or hypnotherapy for that matter for our patients. So this is definitely something that's growing. And I think it's really encouraging that the opportunities there for APPs to also learn hypnosis, cognitive behavioral therapy, very specific. Right now, we're starting this proof of concept study on patients with IBS, but we've started looking at some of Dr. Kiefer's work that I've been following for several years, and looking at that work specific to dysphagia and more foregut issues is also exciting. So I think the short answer is right now we're trying to gather some data to show that things are actually progressing and it is a model that can work. And I hope that we can advance that model and use it in other institutions as well.
Thank you.
I have a question for the APPs. One of the challenges that you guys really nicely highlighted in all of your talks is sort of the difficulties in managing symptoms in patients who have benign foregut disease, which is a lot of what we are talking about. When do you guys think is the right time to sort of introduce the APP in the care model for these patients who are referred for procedures? Usually they'll see Ben, Charu, and me for something, endoscopy, an EUS, robotics, something. But we know that that's not going to be the end of it. So when's the right time to introduce the APP in that care model?
Okay,
That's a really good question too. Go ahead, Alex.
I think as soon as possible, ideally. I think that a whole idea is that it's a team, based in collaborative approach. And so if the patient understands that from the beginning, that the APP is involved, and it's not like you're only seeing the physician or only seeing the APP, but really working together, that's really the best way to do it is right away.
I actually agree with that too.
I think of that first visit too. So if they have a procedure, for example, and then they are coming in for a follow-up, and if they're seeing the physician, the APP can pop in for a minute or two, or vice versa. I think that confidence that the patient has that like Alex said, there is a team, that the physician and the APP are very, working together. It's in their best interest for their continuity of care.
Yeah, that's, also like with what I kind of touched briefly on in my talk, where, we're able to kind of follow up more frequently in between the visit with the physician. I think that's really kind of helping to, especially the patients who are really having a difficult time and they need more of a, side-by-side approach with someone to help say, let's try other things in between. But I find that I can connect with the patient the most, and the patient feels most comfortable when they can start seeing me as early as possible in their medical journey, and then continue to find me as a resource in between visits.
Yeah, I definitely agree with that too. So definitely seeing them as early as possible is very beneficial. So even if, the provider is doing the consult and I just walk in even to be introduced, that's absolutely fine. But even if that's not so, usually a post-procedure follow-up, I'll actually extend that visit a little bit more so I can actually introduce myself, make sure the patient is comfortable. especially after going through a procedure and they're having symptoms, I want to make sure that they're doing okay. So I'll usually extend that visit a little bit more to make sure that they are more comfortable with me too.
And I think if you're working with an APP, one nice thing to consider is a letter that might go out in the beginning of like when the patient gets their appointment. And it's something that, you know, we would like to start in our practice too, is just something that I've done in motility. Is just the physicians I work with, like my name is on there. I think Christina, you may do something similar so that when the patient has the appointment, they know that they may be seeing an APP and that's okay. That's actually a highlight. So I think that's something that others can incorporate in their practice.
I can tell, you know, from a different perspective. I find that having the APP in this multidisciplinary group is sort of the key to the multidisciplinary group, because I think the patients, first of all, they love it. Secondly, they find that between the different providers, if it's a gastroenterologist versus a surgeon and other person, I think they find APP as the common sort of the source that they can go to, they relate with, they know it's a team. And I think that overall the patient satisfaction, the patient experience is far better, and the care is more coordinated when the APP is there. So I think APP is the backbone of this.
Totally agree.
Yeah.
Looks like we're also out of time, but we will actually have a dedicated session on Saturday for how to incorporate an APP into your practice.
Yes, absolutely. And with that being said, I do want to go with a little conclusion here too. So thank you everybody for joining us for this APP session of the MINT Foregut Conference. We hope you enjoyed it. We would like to thank all the speakers for providing amazing education on the foregut topics that were discussed. And additionally, we would like to thank all of you who are watching today too. So we hope you were able to learn something new about foregut diseases and therapy. We hope you have an amazing day and see you at the rest of the conference.